This is Vish here. My full name is Vish Viswanathan. I'm the managing principal and CEO of C Solutions. I know many of you in the audience, and those I know already, hello. And those I don't know, definitely we would like to talk to you and connect with you. Our 3 C stands for connect, communicate, and collaborate. And so we have connected. We connected with AeHIN about several years back. We have been collaborating, and we were involved in providing several training courses for many of you in TOGAF, Archimate, and many other disciplines. So with that brief introduction, I'll introduce my colleague, Uday Bhatt. He's located in Delhi, India. So he's more in a more civilized time. I was actually, it's past midnight for us. So I didn't realize that there's 3 hours difference between Manila and Sydney. So however, I think it's going to be a late night or early morning for us. Thank you for that. I'll continue, please. Today's agenda is, what we're trying to do here today is that a lot of presentations have been given on COVID. COVID-19 is the biggest issue for all of us all over the world. And in our lifetime, I think we haven't seen anything like a big disruption, both for our well-being and wealth. That means both for our health and economy. And we are all sort of trying to grapple with the new, what they call as a new normal. In this situation, we thought we should try and think about the traditional, well-tried enterprise architecture principles. I will also give you a brief definition of enterprise architecture for the purpose of today's discussion, for those of you who are new to this. And we would look at how certain events or alerts. Today, we have got the biggest disruptive event, and how that event has opened up the cracks and in fact highlighted the fault lines in many different countries. So every country had fault line in the the basic medical system, in the health system, and those fault lines have been exposed because of COVID-19. So the question is, how do we apply this to the today's position? So that's the presentation. And in terms of the today, this is very brief thing on our slide on our company. C Solutions, we actually live and breathe architecture. Our major focus is developing architecture talent across the globe. We got people positioned in different parts of the world, including lots in Asia and also in India. Next one. So a very brief introduction to enterprise architecture. We can give a whole, a whole day session on enterprise architecture. That's not the objective. So there are many definitions of enterprise architecture. I would take one from the Gartner, which is very relevant to today's discussion, because it talks about disruption, the disruption like COVID-19. The enterprise architecture is a discipline for proactively and holistically leading enterprise responses to disruptive forces. The biggest disruptive force today, we talk about COVID-19, by identifying and analyzing the execution of change towards a desired business vision and outcome. There are some key words here. Of course, the one is disruptive forces. Today we talk about COVID-19. How the enterprise, or in our case, how the public health system or private health system responds to the disruptive forces. By identifying and analyzing the execution of change, it requires for a massive change, and it caught all of us by surprise. So when our enterprise architecture itself is not ready, we are hit with an external force, and how do you manage it? That's our challenge. So I would like to try to address that using as I said, the enterprise architecture components. Before we go into the detail, I would like to introduce the 4 components that make, or 4 ingredients that make success of enterprise architecture. First one is a comprehensive framework. What does the framework do? The framework gives the method and the process and the step-by-step approach to how do you move from where we are to a future state in the event of a disruption. And of course, here we will be referring to TOGAF. For many of you are certified in TOGAF, but those who are not certified, TOGAF stands for the Open Group Architecture Framework. It's virtually the de facto standard for enterprise architecture. So those of you who are familiar will be able to relate to that. Those who are not familiar, you can actually, go into details next time. The second one is, of course, a consistent notation. Having a framework is one thing, but if you have a framework and you draw some models, you can have boxes which represent applications or processes or whatever, unless these mean the same thing to all the stakeholders. In the enterprise architecture, at any time, an enterprise architect deals with different stakeholders: business, health information professionals, IT infrastructure professionals, IT application professionals, data architects, data scientists, several of them. So to have a common understanding of common visualization, and we look at the model, they should know what it is. So actually, to have a meaningful two-way communication between parties and among the parties, we need to have a standard notation. The notation that has been developed over the last 3 or 4 years is called ArchiMate. Again, those who are not familiar can Google and find out what it is. It's come from the very strong research background in Netherlands, and the Open Group has taken it up, and that actually completes the TOGAF architecture model. The third element I would like to talk about is the tool. There's a tool. There are many tools which are certified both for TOGAF and for ArchiMate. The one that I would like to highlight here is BizDesign, that has also come from Netherlands. That actually truthfully represents both this framework and notation. The fourth element, of course, the most important element for success is people. The people element, people got certified. And why is certification required? Because certification ensures standardization. Certification ensures certainty for both for the client and for the provider. So these are the 4 elements. So again, talking about enterprise architecture, generally we talk about a futuristic architecture. That means where are we now as is state? Where do we want to go to be state? And it's actually a planning exercise, a strategic planning exercise. However, there is another architecture which is caused by disruption. That is not futuristic. We have no time to think, no time to plan, no time to draw diagrams. It's here and now. So that's what we are talking about today. How do you address that using the modeling techniques of an architecture which is architecture change that has been caused by disruption? In the context of e-health, overall, I would like to say there are 3 or 4 different levels. The enterprise could be considered as at the public health, at the MOH or Ministry of Health level in a country, public health architecture, or it could be considered as the area level. For example, we live in Australia, there are different states. There's a New South Wales Health, Victoria Health, Queensland Health, and things like that. And within New South Wales, there are different areas. There's a northern district, southern district, northeastern district, different districts. So in many countries, it can be considered the state level or the local level. That becomes the focus of our enterprise. Of course, if you go down to the next level, at the hospital level, many of you are hospital professionals and health professionals. We always talk about hospital of the future. The hospital of the future is actually the target architecture for enterprise architecture at the hospital level. Today, I'm introducing another thing called event-driven architecture. Today, we have a disruptive event, as I keep repeating, it's about COVID-19, and that actually drives the architecture. The trigger for the architecture is not future planning, futuristic planning. The trigger for architecture is an event. Next slide. So I'll hand over to my colleague Uday to actually take you through the how do we map the enterprise architecture processes and different terminologies to current situation, which is a COVID-19 event-driven architecture. So, Uday.
Thank you, Vish. It was a very nice synopsis of today's objective, and welcome all of you on board. Myself, I am not a healthcare specialist. I am an IT specialist. So certainly certain examples or certain use cases which I am going to discuss is having some biasness towards my own country. So I think there are certain things which is getting done in India differently, maybe in your country differently. So that gap may be there over there. Just to begin with, the covidanalysis.com, they have given some few statistics and it is slightly old, 5 days old. So if I take today's data in Delhi, 46,000 new COVID patient already got added. So run rate which dropped to 500 now increased to 6,000 per day. So it is having the waves impact, and based on waves, the hospital, government, healthcare workers, professionals, they need to adapt to the situation. Now, how to model this all stuff in a TOGAF way? If I go with the complete detail of every use case, then it would have been very complex modeling. But just to keep it very simple for a shorter period of time, I took one use case and tried to map with the Archimate model. So events and alerts. So there are global events, there are country-specific events, and there are local area events. Obviously, global events will be declared by WHO if it is for healthcare kind pandemic or vaccine or whatever. Country level, it will be the policy, maybe improvised or adapted as per the WHO guidelines. And mostly the central system, Ministry of Health, they provide facilitation and monitoring. But in local area, it is all the computation and prediction. So this is something very typical and very common way of getting the prediction that the aggregated hospital capacity to handle patients is equal to daily increment rate minus daily recover rate minus daily disease rate. So if the hospital capacity is more than this particular sum on right hand side, then we are in a very stable situation, we can handle it. And I think every healthcare professional understands that. But if in other way around, if the daily increment rate is more than the hospital capacity, then it is a situation which is a big alert or a big event needs to be managed. So in this healthcare pandemic ecosystem, as per TOGAF, we decide principles. There could be many principles, but there will be isolation, research, and prevention. Isolation is for the people who are the most probable getting infected. Research is for new vaccine, and prevention is better than cure. It is a very common principle in every healthcare, whether it is a pandemic or non-pandemic. And what the capability is, and there could be a very big capability. So in this ecosystem, reworking the value chain from vertical to horizontal and digital interaction, and we will look into it, how it goes. So in TOGAF, any principle, the sample principle is documented or modeled something like this. So if the principle itself is isolation, so it has 3 areas. All infected should be quarantined. Physical distancing is a must. Affected areas can be categorized and ring-fenced, or you can put it lockdown. And the rationale behind this principle is, by this principle, the spread of virus can be slowed down so that the hospital capacity could be managed. Now, during that slowing down, you can either increase the hospital capacity or you can adjust accordingly. That totally depends upon the situation or the SOP as per the Ministry of Health Affairs. Implication is, because we are going with ring fencing, a lot of investment is required to increase hospital capacity. That is the expense, as well as even the country's earning due to lockdown will lead to economic slowdown. So there is a double issue on the financial front, plus other people front and all those things are there. So this particular whole detail can be modeled something like this. So this is a notation of principle. So I have written isolation, meaning quarantined, and then what value will trigger to this kind of isolation. The same formula which I have shown earlier, hospital capacity to handle patient is equal to that formula is written. So small modeling of the principle can be done. Now moving to the complete strategy, which is called prevention. So what is our goal? Right now, we don't have a very full-proved vaccine. Every vaccine is under trial situation. So right now, only thing is we have to put this pandemic under control by isolation and prevention. So this is our goal. So this is a notation of a goal. It is associated with the capacity of patient. So this is a kind of assessment. There is a requirement of hospital capacity, and then there is a course of action is improve infrastructure. And then there is a stakeholder. Stakeholder is majorly patients. I am taking right now here, we can take doctors and we can take other staff as well, but the impacting one is the patients. And then if the patients are in morbid condition, then they will go for hospitalization. If they are normal patient, then they can go for home quarantine. And with morbidity, they have to, the course of action will be admit in hospital. If number of patients are too big, but they are not in a morbid situation, then define the containment zone, that's the requirement. And so course of action is isolate the area. And here we improve the infrastructure. So that's how we model any kind of strategy through Archimate model. And if we write down certain labeling of the notation, then it will be good enough to explain how we want to strategize it. This is a kind of generalization. These are the flows or influence. These are influence relationship. Because when patients are increasing, your capacity getting influenced either positively or negatively. So if patients are decreasing, then your capacity is getting increased. Buffer capacity is getting created. If your patients are increasing, then your capacity is having a negative influence. So all these dotted arrows is called influence. These are certain realization kind of relationship. These are assessments and these are requirements. That's how we define the whole strategy prevention. So I can write it down in 2 pages also, or I can depict it in one single slide. Then what is the actual vision? So if this is done in the TOGAF preliminary phase, then the architecture vision phase, we can have certain vision statements. So prevent till cure is available, that is fine. Citizen mobilization. Now citizen mobilization cannot be always done by IT infrastructure or news. That is one aspect of it, but plus human touch and other things needs to be given. Real-time proximity analysis and alert. Now here I found out a very big gap still existent. And here I am taking a typical example of India. There's an app which is called Arogya Setu. Some people might be knowing over here. Now that mobile app gives you the flexibility of self-assessment, and that also tells you that within 500 meter, 1 kilometer, 2 kilometer, up to 10 kilometers, how many active COVID patient is there. Lekin think from my perspective, I am a common person and I am not interested probably in knowing how many people are there in 500 meters. What is my actual worry is that unknowingly or by mistake, if I am coming in contact with any active COVID patient, does my mobile app put a buzzer or generate some alarm without letting the second person know if this guy is an active COVID patient? so that accordingly I can take a step. I can create some distance, some little more distance than the 2 meters, which is defined, or I may simply pass through. So that is a very big gap with the mobile app which is existed and which I am using. It may not be there in other countries, but yes, this is a very big gap. Then coming to the interoperability. First of all, as per the regulatory compliance, because patient data cannot be shared, the interoperability between different hospitals is already very weak. But then we have to have a integrated system, hospital management system, laboratory management system. And when we are talking in terms of pandemic, then it should also integrate with global positioning system, so that when we are doing ring fencing or lockdown or any type of containment zone, that can be monitored automatically. Data consolidation from district to central level, it should flow. And then analytics and prediction based on daily rate. And then depending on the weather conditions, pollution, if there is any adding factor towards the life expectancy of the virus. Because doctors say that in summer, the virus may be on the surface for say 24 hours. I may be wrong with that data, but I'm just giving an example. But with the pollution and with the cold condition, it may reside for 48 hours or maybe more. And it can stay in the environment more with the pollution. So adding all these factors, people can predict what is the daily rate, and that's how the event and alerts can be generated. And that's how event-driven infrastructure and event backbone and event server can be implemented. So this is the second phase of TOGAF. Now moving to the third phase, that is called business architecture. So the green ones, I assume it is already there and in place, like hospital management system, pathology management, inventory, analytic prediction is there. Logistic management, I made it yellow because when I say logistic management, normally it is not a part of hospital. But when we are talking in terms of ambulances and other and patient movement from one hospital to another, somehow that is not in place. But yes, certain things are there. So I put it in yellow. Mobile application and GPS is not part of hospital. So I made it a very neutral color. But yes, they are also partial. GPS is fully available. Mobile application, as I just discussed, is partially available. Analytics and prediction is an evolving thing. So with machine learning, it will evolve. And proximity sensor is not at all there, at least in my experience. So the normal citizen's desire to get the alert is non-existent as one of the business capability till now. Now this capability, business capabilities, can be modeled in terms of process in the same phase, business architecture. And this is only one simple use case which I discussed, that patient, traveler, or suspect. Patient is a normal patient at home, he develops some symptoms. Travelers means who is coming from some other countries. And suspect means he is neither a foolproof patient nor a traveler, but yes, he has been somewhere, so he is suspecting. And he developed the event like high fever, breathing issue. So he will trigger the process of pathology. So he will give samples to the pathology, which flows to the test of COVID. It may be that RT-PCR test, or maybe that antigen antibody test, whatever. There will be report generation process, and then it will flow and generate an alert. If patient is a COVID patient, then the data has to go to government, and depending upon his situation, if he's a normal, not a morbid patient, then he will send to home quarantine process. Otherwise, he will be admitted to any government or private hospital. Then treatment process will be there, Once he is treated patient, then event will get triggered for his release. So this is one very simple use case. We can keep on detailing. Now we can even create if and else test COVID. So whether it is RT-PCR test or whether it is antigen test, even if RT-PCR test, if condition is morbid, then what all other tests. So it can be a very complex one. Once this particular process is done, then we identify what kind of events will be there. There will be laundry list of events. Alert event is anyway coming from the global. Rate alert will come from your local. Capacity threshold alert will come from the rate alert plus the comparison logic. And then this capacity alert will also trigger to inventory threshold. Now, when I say inventory threshold, right now here I am not talking about the inventory of the hospital capacity, because that event is already at a separate. Here I am talking about inventory threshold about the other things like PPE, kit, syringes, medicine, and all those stuff. And then it goes to for build inventory, and when it goes to procurement, then order event will be triggered and then fulfill function. And then it will so on, logistic will trigger and so on and so forth. So these whole events will get modeled over here. And then we are to create event-driven architecture. In IT infrastructure, I am just giving you one analogy. In the cloud deployment where B2C or B2B is there, they put event server, which is a specialized server, and they also put an event broker. Why they keep this event server and event broker? Because during the festive peak time, the companies might require additional compute time, additional memory time, and additional storage time. Now, there is no one sitting here to measure and allocate it. Everything is automated. So they create a rule in that event server, and as soon as that threshold is touched, the event get triggered, and all those things, extra facilities, what is required, they got allocated to that particular service or get provision to particular service. Event server is an expensive one. Event backbone is also a little expensive, but it is very useful when a country like India already have a inbuilt GS-WAN infrastructure in place. So the structure will be something like that. There will be a patient system. This is just an artifact example. Application event broker, who is going to take event either from hospital or from lab, and both are in collaboration. So this is a collaboration notation. This is event notation. And this collaboration will pass this event to application interaction, which will give to analytics and reporting and GPS. Now you will ask question why collaboration will go to GPS analytic reporting. Because look, once a treatment has started, that is a separate path. But once my capacity is increasing, analytics will tell me where I am, and GPS will tell me which area needs to be ring fenced, which area needs to be put under containment zone, and how much area should we contain. Because if I am not wrong, in Delhi, in the very first month when they started creating containment zone, they created a containment zone so huge that the population got perturbed, because only into some section the patients were there, but still they are in quarantine who are not actually suspect patient or not at all in attach. So we need to know the localized area so that those who are not infected, they should not get bothered, and those who are into that quarantine area. So that precision was missing, because that all was manual decision that 6 districts we are going to quarantine. Today I heard that in South Delhi, they have quarantined 41 areas. Now 41 areas, that means you are locking down the whole South Delhi area. So people will not accept it, and that's how people get a opposition, they oppose. So this GPS and this reporting will help you to actually ring fence very precisely and properly. Yes, some buffer can be taken. So that's where this event-driven architecture helps. And then everything needs to be integrated. Now, in the beginning, I told you, due to this privacy, patient privacy concern, data concern, data sharing among even hospitals is not that easy. But for pandemic situations, some regulation needs to be relaxed, that this type of when situation is there, then hospital lab should be interacting. Now, interacting means this lab may be anywhere else, this hospital could be anywhere else, but by giving some patient ID, it should pass through. Then it should also talk to reporting. It should also have a rule engine. It should also have alert isolation. That means it will go into that event trigger. It will generate reports for zones. Then it has a collaboration with GPS and so on and so forth. So a complete interoperability system is required. And so far as the data which is going to pass between this system, it may not be very huge. It will be very small per patient. But India has a very huge population, so aggregate data will be huge. But yes, it is not going to come in one go. It will come slowly. So that federated system will help the complete integration. After integration, we are going for the data. So this data is all about metadata. It is not the actual data. I have the forms, entry forms and data, but that will take too much time. So data principles are timely, accurate, reliable, complete, private, confidential, secure. Problem is with timely. Second problem is complete. Confidentiality is fine. So timely data and complete data normally not available. And again, when I am passing this comment, this is very limited to some experiences, not attributed to everywhere. And this is not available due to the patient psychology, because he or she believes that as soon as I tell that I am a COVID patient, I will be put under quarantine, and then they take it in a very different way. So this timely and complete data is not available. But yes, these are the principles. Data we collect based on passenger. N is normally we say novel coronavirus. That's why NCOV. So passengers and patients. Then what is the state level logistic hospital, then district level hospitals, then state buffer stock and district level buffer stock. When we blow up into this, then we have to have all the data, including patient plus buffer and everything. Now in technology architecture, I made it very simple at a very high level. There are two types. One is consolidation. So GS-WAN, if you see, GS-WAN is an internal government provided infrastructure of communication, which is fiber optic across India. So whether you have a private node or public node of HMS and LMS, hospital management system and LMS system, which can be joined with GPS local, can transfer the data through GS-WAN either to state data center, and then state data center pass the data to central data system. When I say state data center means like there are states like Delhi, Maharashtra, all these things. So they will pass there, and then from that data center, it will go to Central Ministry of Home Affairs, which owns that particular data system, where all the analytics and prediction will happen, and they will generate some SOP or some improvised guidelines, which will pass through to all the states. Second is contact tracing. So state data center, GS-WAN, central data and GPS will remain the same. The only thing comes that telecom operators who are providing these mobile services, and because the Arogya Setu is a native app, it is not a web-based app or hybrid app. So it will pass the data, and then from these telecom operators, their responsibility to, from their own data center or server, they connect to GSWAN and pass the data. But the whole problem is again, does this native app, when come into the proximity with another person, does the Bluetooth connection gives a trigger or alert to an individual person about the second person? Then, now when we are doing all the interconnections, so what I have done so far, I went preliminary phase, then vision phase, then business architecture phase, then little bit on application side, then data side, then technology side. Now, when we consolidate and interconnect everything, so the comprehensive model will something look like this. So this is the same use case which I have taken from business architecture. It is talking to my applications. So hospital pathology is there, MI applications are there. So light blue are applications. These are facilities. So these are containment zone, this is pathology zone, this is hospital zone. And because these facilities are related with this, so they have to realize these applications, and they are getting served by hospital server or pathology server, and they talk to network GSWAN, which go to government data center, to Ministry of Home Affairs server, and also get served by GIS or GPS system and generate MIS. So this is
Uday, one comment, Vish here. One comment I want to make in between is that the enterprise architecture, those who are not familiar, we talk simplistically about these 4 layers. Business layer, which deals with health systems, applications and data, then technology layer. So that's what we are trying to show here. You don't have to understand everything for those who are not familiar. It's only to show that it's possible to interconnect everything. And the whole idea of interconnection is what if analysis. Think about what happens. And when you know the entire system, how the business processes, how the applications, how data and technology are connected. If something goes wrong, what if? What if this technology fails? What if there is a new, new data set comes through? What if those kind of things are easy? So that's what you have to think about. This facilitates what if analysis. Sorry, Uday, please continue.
Yeah. So in this particular interconnection, if you remember, the strategy component is missing. So in the next one, I have also added this strategy connection, and now I am mapping it with the, you can say, with TOGAF. So this preliminary goes with this one. Your vision phase will also be a little bit from here also. Business architecture, your application data will be this part, your technology architecture will be all of these. And after implementation and migration, whatever the result will come, that result will be coming over here. So all the phases of TOGAF, because this is just a governance and this is change management, and these are requirements. So this is a process part. So that I have not drawn over here, but I tried to map with all the TOGAF phases in a very simplistic view. So I have taken from the principle, goal, then assessment, then stakeholders business, then facility, and what are the actual we want to compute, which is all about rate versus capacity, so that we can prevent and take proactive action, what we wanted to do. Now the same thing we can put it into a different format, that is value chain. So in value chain, there are 4 things, channels. So in channels, we have public, private, hospitals, and labs. When I say public and private, I have already taken the channel of mobile. So it is inherent. I am not explicitly mentioning it. Patients is of 2 types, asymptomatic and symptomatic. These are more dangerous than these. Products, hospitalization, treatment, testing, quarantine. These are certain products. Operation, hospital management, pathology management, clearing and settlement. Clearing and settlement, both. It is a very high level. So hospital clear settlement, your insurance settlement, and all those things will come into picture. And all can be integrated by means of IT management, MIS, analytics, GPS, and public-private partnership program. And I will come to in the next slide why I'm emphasizing onto it. Government regulation, here it will be some old and some new ones. HL7 for the patient data, and HIPAA compliance is for your insurance, if insurance is there. Deployment may not be required that much except the mobile one. Channel management is mostly the mobile one, and plus the physical hospitals, and product management can be improved. So that's how we create the value chain over here. So the digital ecosystem. In digital ecosystem, we have center, event, and interaction. We have government, we have hospital, we have pathology lab, we have GPS, we have traveling passengers, we have patients, we have vaccine companies, we have insurance provider and TPAs, we have banks. This is just one aspect of it. Now, if I increase in the hospital, then there are companies who are going to come at B2B, and for patient, the company which come into B2C. So it will expand isometrically. But this is a digital ecosystem. Now in digital ecosystem, I have written from vertical to horizontal, what I am trying to say over here. In a normal situation, hospitals are very specialized and they have a vertical system. Like this is a nephrology department, this is a cardiology department, this is oncology department, and so on and so forth. Even hospitals are specialized. And then there is a general OPD patient, all those things are there. As this particular pandemic came into picture, what government has done? All the OPDs for the specialized vertical got stopped. Now they have started doing it, but it got stopped for 6 months. So if somebody is a nephrological patient and if he is not in a critical situation, they said stop, you keep continuing your same medication and we will see you when things are normal. And all those facilities which are available with those departments has been given to the horizontal section, general section, where all the COVID patient which are either put on quarantine or on treatment can be entertained. So the whole vertical system, which are very siloed, they have broken down. Plus, they have also expanded that generic method, but right now vaccine is not there. So all the treatment is trial and error method. Somebody has a plasma therapy, somebody has vaccine therapy, and somebody is even good with crocin. So it totally depends upon how somebody gets corrected. And I am not sure, you better know how everybody gets treated. But everybody obviously is not requiring the ventilator treatment for sure. So they even expanded this quarantine and little bit of, you can say, kind of first aid system to the hotels, residential hotels, and they created even the football ground or park into big quarantine centers. So this whole transformation, so they started with hospital, and when they consumed up that capacity, then they went into the hotels and parks. So that's where I'm saying that they have broken the vertical structure for a temporary period and make it more horizontal. So only very senior and specialized doctor are, I think, are barred, but rest everybody is involved in this particular activity. And plus they also called all the collaboration from hospital. Look, government hospital will anyway do because government mandate is there. They also mandated the private hospital. In India, every private hospital has to publish how many COVID beds are available, how many consumed, and they have to take the patient. They cannot simply say, no, we can't take you. And even the fees is got, you can say, fixed by the government per day, per person, whatever, depending upon what facility the person wants. So we have to prepare this digital ecosystem. We are breaking from vertical to horizontal, and we are collaborating. And that's where the public-private partnership comes into picture. So this is the whole system. So we architected it in a TOGAF way for simple use case, map with a value chain, and that value chain can lead into the integrated whole digital ecosystem to handle not only COVID. If we actually implement it, we can handle any pandemic, and that event server will help you not to utilize all the uh, systems every time. When required, you use it. If not required, let it go. So nowadays it is cloud. So we can do that. So that's it from my side. So now the forum is open for questions, concerns. But I think I am on
Uday. Thank Uday, but Vish, conclude the thing. This is not expected to be a complete, integrated system for discussion, because you doctors and health professionals are much more familiar with this whole situation than Uday and myself. Basically, what you wanted to show was it is possible to map, using some use cases. It's possible to map the entire ecosystem as an event-driven architecture using TOGAF and Archimate as the notation. That's all we wanted to say today. Thank you.
Hi Vish, Uday, this is Alvin. Thank you for the webinar. I think it's very useful to know that there are methodologies like TOGAF to help us manage the complexity. It's very, very complex right now. I think the countries are really reeling under the stress of the urgency of the things that need to be done. That's the event, and how to organize all of the complexities into an orderly set of artifacts, as you're now showing us on the screen. I was thinking that what would you recommend to governments as a first step? You had a slide, in the earlier slides, you had the 4 components of an architectural practice. If you can go back to that, of the four components, which do you think government should go for first? That's that one.
Thank you. I think again, it's the same for either it's a government or an enterprise, whatever it is. What we do is we actually first go for the framework, even a simple framework. It's TOGAF or doesn't matter, whatever framework. It has to be customized. The framework has to be understood and customized. I think that's the first part. Customization of the process, customization of the artifacts, customization of what we want to do, the goals, and clear understanding in the planning phase. That is the most important place. As you know, they said well planned is half done. Okay, so selecting the framework and customizing it, that's the first part. In India, they started with IND-EA. IND-EA is based on TOGAF, as you know, and I'm not sure how far it's connected to the health framework that they're thinking about now, but the intent is there. They put a lot of effort into using TOGAF as the basis and create IND-EA, IND-EA as the framework. That's the first part. The notation is the second part, because having got the framework, if you don't have a proper notation like Archimate, you don't know what it represents. All the stakeholders can't understand. So I would say these two things are important, along with, of course, certified professionals. But the tool, the question on tool is, varies. Some governments say that we don't want to, go into the tool warfare now. Which tool? Let's use Visio and PowerPoint, and let's actually communicate to start with. The other approach is take the cheapest and the simplest tool and use it. It doesn't matter if it's not sophisticated. You have something to, proper version control and all that. So I would say that as the third one. I don't know if I've answered your question.
Vish, now that I'm seeing the 4 components again, may I venture my own answer and then correct me if I'm wrong?
Yes.
I was thinking that the comprehensive framework is already there. This is already established by the Open Group framework. The consistent notation is already there. There is Archimate already. the tools are actually results of people making decisions about what tool to use among those that are already available. So I was thinking maybe the first investment of a country would be the people. To get these certified people, identify them. If they don't exist within government, then they should hire consultants first who are certified to just get things going, moving quick enough. And then as they develop their own internal capacity for certified enterprise architects, slowly transition from external consultants to internal enterprise architects. So I would say people. What do you think, Vish?
Yeah, fantastic. That's, I mean, I should have said that because what's happened in Bhutan, I don't know if Garab is there. So what happened in Bhutan is a very good showcase. They first went through a training course where they trained a core set of people in TOGAF and Archimate so that they know what it is. And then since they could not start it, they went for a tender for an international consultant to come in, act as a mentor, and the mentor holds the hands, hand holding of these so-called architects, and gradually they implement. They implement, go through 1 or 2 cycles of TOGAF to learn through implementation, by actual implementation, and then they take over. That's the kind of thing.
Right, and therefore, if governments just knew, they don't need to be experts in enterprise architecture, but if they knew about the existence of a comprehensive framework like TOGAF and the existence of tools, notations like Archimate, they can make that part of their tender. And if they knew that there are certification programs, they could make that part of their tender, that they're looking for certified people, certified to advise them about a comprehensive framework like TOGAF, and certified to advise them on the proper use of the notation, including maybe training, so that after a 1, 2, 3 year program, rather than wait 3 years to build internal capacity, they can hit the ground running with experts already helping them out on day 1, but also have the internal capacity to absorb the enterprise architecture work maybe after 2 to 3 years. I think Bhutan is doing it the right way, that way.
Thank you, Dr. Alvin. You put it more succinctly. Very good. I think there are a few other questions. I don't know who is going to take. Is Cha going to monitor the questions?
Yeah, Cha, do it because I'm on a phone. I can't really see the font right now. Cha, could you read the questions?
Yes, we have a question from Dr. Rabindra. So, using proximity sensors, the app will detect the infected person near to us. How is it done, and what about privacy of the infected person?
Uday, from your experience in India, please.
Yeah. No, proximity sensor is not there. That's why it is red. Let me go to that particular slide.
Right. While Uday is looking for that slide, I think coming from my previous question, Vish, we can ask Garab and Bhutan to tell us their story, how they started their enterprise architecture journey. Thank you. Cha, please remember that. Let's invite Garab over.
Noted, Dr. Alvin. I think this is the slide, Dr. Rabindra. Are there other questions from our participants?
I have a question, Cha.
Yes, Dr. Alvin.
Vish, Uday, for individuals in the call, and maybe if they're representing their organizations, and in my previous question, I focused on the certified people as the first step that they can do. What would be these certification processes? How do you get certified in TOGAF? Over.
Okay, thank you. Thank you for asking. I think the TOGAF certification is, there are 2 methods. One is, of course, one can read through TOGAF and understand it and go for an exam. You have to pass an exam, external exam. But it is because it's complex and very difficult. There are actually certified training courses. There are authorized training providers. And these authorized training providers, you go to the TOGAF website, www.togaf.org, TOGAF, the opengroup.org, you will find a list of certified trainers, including ourselves. We are not the only one. There are many of us. So you go to the certified trainers and select your trainer in your region that is going to give you a comprehensive understanding of TOGAF, and not only helps in implementation, but also actually helps them to pass the exam. So once they pass the exam, there's a certain amount of certainty that at least they understood the basics. So that I see is the first step in terms of attending an authorized training course and passing the exam.
Thank you, Vish. And I'd like to speak for, as I mentioned in the chat, our first teacher was Vish when we had our training on TOGAF in Mongolia way back in 2013. That's how far back it was, Vish, already. That was 7 years ago. And I know for a fact that one of those that you trained, Vish, became a CIO of an organization. And I myself became a CIO of my own organization. I think the certification helped us a lot, getting those enhancements in our work. I think the ability to be able to show to your employers or future employers that you are certified in enterprise architecture gives you a lot of edge over these high positions. Thank you, Vish.
Thank you. Thank you. Uday, I think that question about proximity, I think somebody asked a question. I think what Uday maybe didn't come across to other people is that this we are used like a traffic signal. Uday used a traffic signal approach. From his experience, he's just showing an example. You can use a traffic signal, green, amber, and red. See, where are the gaps? Green means it's available. Amber means that actually it could be improved. And red means it's not available. So he just used this as an example here. And Uday can explain.
Yeah, so right now even proximity sensor is not available in Arogya Setu app, but it is quite easy. As soon as the patient is identified as a COVID patient, his data is there in the system. That data is there in Arogya Setu. And this contact tracing they are doing through Bluetooth. So data is anyway getting passed. It is just a one small program which will create a vibration of alert with some message. So one small service can create and help a patient. And the name is very big, proximity sensor, but actually one normal web service can do wonders and help the other person to be little more safer.
Thank you. I see Miss Jovita Aragon, Vish, one of our AeHIN certified members in AeHIN. She was the one I was mentioning that became a CIO. Right. Jovi, could you say a few words about how TOGAF certification helped you? Miss Jovi, if you have a microphone.
Yeah, can you hear me?
Yes, go ahead.
Yeah, the TOGAF really helped me a lot, especially in getting the position as the Chief Information Officer. And the knowledge that I had in the TOGAF, I inputted that into the enterprise architecture of PhilHealth. It was really a very good learning experience also. So the theoretical has been combined with the real life experience, especially in PhilHealth. But of course, there are other issues that we really have to manage. Over.
Thank you, Jovi. Thank you. We've reached the top of the hour, so I'd like to thank Uday and Vish for the time that they dedicated to us. Also, Miss Jovi for joining us in this call. I'd like to invite everyone again to our AeHIN MIT Data Science Collaboration course. You'll see more of that in our website. Thank you. Good night. Thank you, Vish. Thank you, Uday.
Thank you. Thank you, Chap. Thank you, Chap.
We'll invite Bhutan and Garab in the next call. Thank you.
Yeah. Thank you.
Bye.